Thank you. And I want to also thank my colleague Brenda Alma, who is active on the Fuse group right now. And unfortunately, Brenda was supposed to be here today and had some family issues. She's down in Georgia taking care of her family. But it's a pleasure to be back with this group. I've done this a few times before. And we'll go through some of the things to talk about what happens when we have that failed event. You know, we work in an environment that's sometimes unpredictable and sometimes more predictable. And when we work with high-risk devices like energy, the predictability that we could have problems is on the table all the time, but yet when they're going to happen, never expects us. So not only do we have to educate to respond to the fires like we just saw in the previous presentations, we have to also understand if we're involved in an event, how do we follow up and take that to the process that we want to take through, making sure our patients are safe. We have relationships, especially our physicians and our nurses, with the families of those patients. So how do we know how to do that when we're not emotionally bound into the fact that our patient may have had a significant injury as a result of something we had done everything we could to prevent, but something happened. So that's really a message on why we want to talk about failures in these presentations. Just briefly, in the literature, there are lots of things that tell us the work that we do every day, the use of insulated devices, the use of electric equipment, the use of energy sources, result in injuries to our patients. In the MIS community, we know that insulation failures happen all the time. In our central processing areas, we try to detect them with scanners and those kinds of things to find them. The scrub, the circulator, and the surgeons are looking at the beginning of the cases to make sure that the failures, they can't see any visible failures, but yet there are a lot of them that we don't know about. These are the kinds of things that lead us to say we need to be worried about what might happen when we least expect it. This presentation was uploaded onto the site, and if anybody wants it, they can reach out to me or to Pascal. We'll be glad to get it to you because the references are in the notes for the presentation. Equipment failures fall into a lot of groups, and when you look at the ones that are reported around fluid, lights, instruments, electric, and imaging, we see that we have a lot of them in all of those areas. So that, again, sets the context to say, why do we report them and how? One place to get us on a great first page is to think about using checklists when we design our programs. Checklists put predictability in practice of the team. They help us when we're really through production pressure to make sure we don't skip things we shouldn't skip. And they also are the cross-checks to say, did we do the pauses the way we should? So I would suggest that we use a checklist. SAGES has an MIS checklist that we developed with AORN. This particular one that Brenda's used in this presentation is a little different. My messaging there is most of these can be customized to your institution because customized, predictable checklists that work in your own institution are the ones that you're going to be able to get everybody to adopt and everybody to use and make them predictable, to put those pauses, those safety checks, those insulation checks, all there so we don't have the injuries. But if we did have an injury, we have to learn how to respond to it. And the first thing for all of us is we ask each other, is the patient safe? And then what do we have to do to keep the patient safe? We need to respond to these events as a team response. Our responses should be standardized, understood, and promote communication amongst the team with a role leader, and all of those kinds of steps that we take around adverse events to be able to deal with them better. Education and preparation, while not around a fire injury, I heard from a colleague of mine this week. I was in a field event review of a surgical complication that we had within the last month at our facility. It was a hemorrhagic problem on an MIS surgery. The patient had a major injury. And at the end of the day, when we were sat in the debrief, our surgeon, our attending surgeon for that particular case, had just gone through our crisis drill on hemorrhagic complications in our simulation lab. And in the middle of the response with everybody from legal that was there, she said, I was so much better able to take care of this, and my team was, because we had done it. And it just says, if we're prepared and we approach in a standard way, we know what to do when we're emotionally bound to an event. So that really goes to all of these points that are on the slide, that teamwork and use of evidence-based practices to create a culture of safety are important. We can use checklists to engineer. We can standardize and train. We can practice our teamwork. We can register events, and we can continue to be absolutely a high reliability organization and be preoccupied with what that next failure might be in our environment. But if we do have that failure, we want to be able to report it. The reporting really goes back to 1990. Most of you probably know all about all of these things, but the Safe Medical Device Act was passed by Congress. The MAUD database was created. It becomes a repository for reporting injuries. It's a place where if you're having multiple insulation failures, for example, you can go to see what's in what's in the databases. 26 states are now requiring reporting of adverse events, and the National Quality Forum considers our adverse events as never events, and they need to be reported. The Joint Commission calls them SREs, or Sentinel events, and the Joint Commission definition is that it's an unexpected occurrence involving death, permanent harm, or severe temporary harm, and certainly major burns and airway burns, which are very high numbers of surgical fires, fall into those categories. This really is another list of the same kinds of responses as we go forward. This is also the Joint Commission's matrix, and when you see the colors, and it's too hard to see all of the detail on this, but there's a very high number of those squares that are either that gold color or that yellow color, and those are all either perioperative events that are in the Sentinel event database at the Joint Commission or are in the near-miss database at the Joint Commission. And you can see there's a considerably high number of them as well. So when we have them, we would hope that we also are reporting to the Joint Commission if you are Joint Commission accredited, because they learn from what we know as we move forward. This is a busy slide. It's, again, one we can give to you. This is our process at Beth Israel Deaconess Medical Center for moving through field event reporting. The patient is always at the center. It really has two parts. And do I have a pointer here, Pascal? Yes. Okay, if I can get it. Use this one? Great. The top part of this piece right here is immediate response. And this is what we do. Keep the patient safe. And the most important things we're doing in the immediate response is activating the fire chain. Whether or not you have an injury, you need to, it's reportable to your local fire department. Years ago, I helped debrief a situation where we were working with Boston Fire because somebody had a laser, burnt a hole in the floor, and didn't pull the fire alarm. Well, that was a violation of what, in Massachusetts, we have to do when we have a fire in a hospital. And so even those kinds of things have to be, you have to pull an alarm, even if the fire marshal is down at the door when they come in and say, you know, it was not, we took care of it, and then they deal with it. They have to be, all OR fires have to be reported. In this state, I don't know about other states, but I can only speak to this state. We go through, and you want to be sure you sequester everything. Even if you think it wasn't involved, it was drapes, if it was clothing that was on the patient, everything needs to be sequestered along with the generator, if it's an electrosurgical generator, and all of the equipment. They need to go to people who are going to try to recreate the incident after everything is taken care of. Again, we can provide this tool to you if you want. For you, I went ahead before I wanted to. And the second part of the response goes through reporting it to the necessary people. We have a patient safety coordinator that works for healthcare quality, who's an engineer who helps us with this work. He helps us recreate. He partners with clinical engineering to look at devices, and we move it through that process. When you really get down to the bottom portion of it, this is what happens after the event when you're thinking your healthcare quality makes your decision to go this way. Where do you pull the manufacturer into your review around a device? For the circumstances, and your quality people may say, we want to do it through a third party before we pull the manufacturer in, but those deliberations need to be made at the level in your institution where they're able to make those decisions at the end of the day. And you want to always know what you learned from it. Patient safety report needs to be followed. That provides you the peer protection to be honest in what your response is and what went on. And it gives the person who helps coordinate the debrief afterwards or the inquiry a roadmap to go. The more information you can give us, the easiest our work is, and the way we're able to engage you in a more timely response as well. This is one of Brenda's favorite little cartoons about electrosurgery. Your mother and I are shocked at your current behavior. Until you learn how to conduct yourself properly, you are grounded. So it really kind of fits in. We want to conduct ourselves safely. If we have an event, we want to report it. And it's a pleasure. This is very fast, very high level. There's more content in both the FUSE course and the textbook. And I thank you for the opportunity to be with you this morning.